I like this Jesus, all caps
Fun.
are bad. And I also think this is really funny. I feel like it's my life.
Yes.
No, I'm good. Thank you. Yeah, do it.
No, listen. That's my life.
Why can't I get my mouse to show up on the? The microphone?
Mic, yeah, okay, neither of them are turned on. Okay. Oh, that, yeah, okay, so to turn on, it's just gonna be up.
Uh-huh.
I love the vibe of the microphone is on. Yeah, on the three. Usually that, hopefully that feels soothing and not stressful. And sometimes the music rain on the roof sounds kind of stressful.
I love it.
Okay.
I love it.
It is, I love the rain.
Me too.
I love the rain. I just want to project.
Well, the microphone will help you do that. Yeah.
It could be fast also, like a big downpour and then
Yeah.
taper off really quickly.
I was suggesting that Dominic go first because your presentation is longer.
Oh, yeah, I mean, I basically just like have some like things I was gonna say that I wrote down on my phone. I wouldn't say it's like a whole presentation, but like, basically like saying what the bail fund is and some of the tie-ins for the book.
Yeah. That's
So,
fine.
yeah, that's fine.
Yeah.
Oh, sounds good.
Do you think people will come
I hope so. It's raining
because
a
of the
lot.
rain?
There's people walking in though,
There are.
as
Okay.
we speak.
They started driving before the rain started. That's what we have.
People are also just late sometimes,
Yes. Yes, they are.
but I see several folks who I imagine are here for this.
Dave will be, on the live stream.
Oh, I feel so bad.
know.
We do tend to get a lot of people on the live stream, so
Okay, that's
that's
cool.
also like part of the audience, you
Yeah.
know,
Because it's like Greater North Carolina.
or even, I mean, national, you know, I mean, like.
Okay, before we start, I definitely want to do a sound check to check. It's obvious that the sound works over the speakers. I just want to make sure it's going through the screen. But before we do that, just in terms of who's speaking when, is anyone already introducing you or should I do that?
I'll introduce myself.
Okay,
Yeah, I don't need it. I don't need an introduction.
and then.
I need no introduction.
All right, fair enough,
Yeah.
fair enough. And so then you're gonna start us off? Is that true? No, Domino's starting us off. Okay.
Yeah, are you gonna do like an intro of the event? Or am I the first person talking that would be like, hello, I'm part of AMS?
I'll do like an old, so normally I would like.
I can also say hello. Like I don't.
But
Okay.
you usually do like
I
a
normally
Yeah.
do a little intro. A lot of it is normally like, I'm reading a bio of the author, but I will skip that part and just welcome
skip
people
that
to the
part.
space.
Nobody listens to the bios. Nobody gives a shit, really. I mean, they just
I mean, they're a captive audience if they're here, but
and I need that for my ego. So
okay, that sounds fine. Yeah, so I'll do a brief intro. Okay, so things that are gonna happen. I'm gonna turn the
Hi.
fan up there so that it hears a little more air flowing. And then if we could do, yeah, just a quick sound check, which will involve me, listening on my phone to make sure that the audio is coming through YouTube.
tell us when you're ready to
Okay,
do that.
perfect.
Okay, and then
Hi.
after,
Yeah, great. Well,
I know I invited other AMS people, cause it was like 3 hours ago. that Dave Pipe was like, I can't make it. I'm sick.
Oh.
And so I was like, I will. What are you saying? What's going on? Like, I knew this was happening, obviously, and I already planned on going,
Yeah,
but I didn't know how much. I'm like, did you prepare a slide, you know? And they were like, no, I'm just gonna talk about AMS, and they're also in the community paramedic program, so that would have been
that's cool.
cool.
Cause they actually do work at the jail.
Oh, that's
So
cool.
we're like,
There's
kind of-
paramedics in the jail.
they're not in the jail, but they have like some kind of, and I really don't, Sarah might be able to speak to that actually. Like, there's some kind of like handoff or the ability to have a handoff from the, MAT program. So that when people get out, they have access to, if they were doing like medication assisted treatment inside, that
Nice.
they like have some kind of bridge to resources.
Like a navigator.
There's actually a vending machine in the jail lobby that has free, it's like a vending machine style, but it's free, like naloxone and like all kinds of stuff, which is cool.
So cool.
Yeah, like you can just go in there and just be like, boop.
I love that.
Yeah. And they're like grant funded. It's only like 4 years old, less. I can't believe.
Yeah. Yeah, because it was like post COVID.
Yeah. Just like, you know, an alternative to not having to tell the cops. So they're just like roving. They're answering calls, but they're just roving around all the time.
Pretty cool.
Yeah. It's
We give a lot of rides
yeah.
to people.
Yeah.
What does that mean? Give rides to people.
Actually, just like, hey, you need a ride, you're walking
Oh,
somewhere,
okay,
you know,
okay.
like
I see.
actually, yeah. A lot of like,
Do you want a sound check, Liberty?
Yeah, give me 1 second, I'm gonna just
Oh,
open
okay.
up the screen.
a lot of things that like official paramedics wouldn't,
Yeah.
they wouldn't be like, hey man, it's hot out, where are you going?
Right,
But
right.
they're like operating a little more ragtag, like above
there.
board officially, but
But
the
it's
things they do.
providing more like social services
Yeah.
than just like, we will help you if you start dying accidentally.
Okay,
Right.
somebody wants to.
Sure.
Hello. Oh,
I
I hear myself on the. Back, I'm good.
Do that again and
Okay.
see if that doesn't happen.
Hello.
Yeah. We didn't, none of us need that. Yeah.
Okay, so I think we're actually getting out of your two sources. You wanna mute, your.
I just did that.
Oh, you did?
I just did it because I was like, it's too annoying.
Okay, and then the only other thing is, we're able to see, your notes field here, but not there. I don't know. do
There's
you
no
have-
notes on here.
Okay, great. Just, I wanted to
Yeah.
make sure you knew that this was potentially visible.
Yeah, that's helpful. Oh, wait, so you see it on Zoom?
Yeah, on Zoom, we're getting this view instead of that view, and I'm sure there's a way to make that be
Yeah,
different,
it's
but
use
it's
slideshow.
possible that
But
we should not stress it.
I don't know. Yeah, that's really possible also.
I'm also happy to get your slideshow later and sub it in to replace the like if you'd rather the final version have like that instead of your workspace. Oh, yeah, that probably resolved it.
But you don't see this, right? Sorry, this part, this, oh no, you do see that. Okay, so I'll make that small.
In the
You don't?
Yeah,
Okay, okay,
Yeah, so that's fine. Actually,
Okay.
that's ideal.
okay,
You've
great.
solved the problem.
As always,
The unsolvable.
as
problem.
always, I mean, give me another one, because that one knows too easy.
Open for now.
Yeah.
Cool. Well, it's 5 after. Maybe we give 1 or 2 more minutes. Anybody need water or anything?
I got this
Or
one.
my little
Last
Or
minute
free.
runs to the bathroom.
Okay.
just did it.
Okay. Okay, cool. Well then, it seems like we've hopefully worked out all the peculiarities. So,
Yeah.
Sounds good.
we'll give this one,
Yeah, thank you. But she's gonna do a little, this is, you know, what the event is. And then you're gonna say,
You all are going first and then I'm gonna go.
okay,
So they'll introduce themselves like before they come.
yeah.
And if you don't want to go in this order that I suggested, that is totally
No, I
fine.
can, just so long
Okay.
as I only had like AMS stuff prepared, so if I had to like be the first one to, I didn't want that to be like,
No,
oh, I'm
no,
with AMS, so this.
I don't really need to be introduced. I think it's really annoying when other people
Yeah.
have to introduce me.
Yeah.
I don't like it, so I don't know why that's like a thing, actually.
Yeah. Not even introducing you, but more of like, is someone else gonna set the scene, because I'm not prepared for like, you know what I mean? Like, thanks for coming out, you know, the little,
MC,
yeah, little schmooze.
the MC
I can
room.
smooth, but
Mm.
I hate doing the thing too, which is funny.
yeah, you can like be good at it.
I probably would be, I just don't like it, you know?
Oh, yeah, hey.
Sometimes we're even good at things that we don't like to do.
Also, I had the invitation is that you don't have to sit up here while I talk for onerous amounts of time.
Yeah, we
You-
might excuse ourselves. to
You
the
are
audience.
welcome to do that, and you're also welcome to sit up here. It's really just up to you.
Thank you. Yeah, because if we were gonna be like interviewing you or like going back and forth
Right.
or like giving you questions.
I'm just like, it's kind of annoying to sit up here while somebody else is talking.
And I'm wearing.
I'm trying to look at the slides, but
And
I wanna see.
I'm wearing like
Yeah.
all white, so I'm like, I didn't realize, I'm like. You look at the screen, it's like most, you can see me the most. and I'm like, no, it's like, not even from a like, don't look at me, but I'm like, I'm visually the focus here.
Yeah, so we can maybe.
It's all right.
Yeah. I'll just crawl.
I don't know that the visuals actually matter that much in this presentation.
Well, yeah, I mean, if I was watching, I'd be like, I chump and said one paragraph, but I'll just crawl away.
That would be best.
Yeah.
That would be best, yeah. Oh, shit, it's doing the closed captioning thing again. Hold on one
Oh.
second. It does this, I do a lot of presentations in Spanish, and so it'll close caption things in Spanish. But it doesn't do a good job.
Yeah.
So then, like, fuck you. Don't do a bad job.
Yeah.
That's worse than
Yeah.
no job.
100%. 100%.
Yes, absolutely.
Yeah, please.
People just don't want to sit in the front.
Yeah,
Right,
no,
yeah.
love it, love it.
You are a hero.
Get up and cozy.
I haven't read the full book yet.
Before
I
people
did.
get super settled too, I did bring 2 bottles of tinctures, you know, the kind of stabilizing blend and then like a more relaxed and
I
Irvine
haven't read the whole book.
blend there above the cardboard box.
Yeah, I
to
would,
the
I
left
can
of
immediately.
this hard rack. Feel free to just get up at any point and say something if you want.
Who that you did.
How do y'all feel about
the-
starting?
The person from Hip Hop Nation.
Great.
From
People can
from
copy
Tiffany.
something
Yeah.
throughout. Yeah, yeah.
Hi, folks. Welcome. My name's Liberty. I'm part of the Firestorm Collective. We're really excited to have a conversation today on abolition and health justice, inspired by Ronica Mukerjee's new book, All This Safety is Killing Us. And Ronica has generously traveled to Asheville to be with us in person today. And we'll be in conversation with our friends from Appalachian Medical Solidarity and the Asheville Community Bail Fund. I think probably all of y'all have been to Firestorm before, but just a few quick pointers if you haven't. If at any point during the conversation you need to get up and stretch your legs or move around, you should feel free to do that. Normally I'd invite you to go outside and get some fresh air, but it is raining pretty hard, so your choice. There are bathrooms, bathroom over here on the far side of the store. If the light's off when you walk over, it'll come on as you walk in. So help yourself. And if you have any questions, feel free to tap on my shoulder or check in with anyone else who works here at Firestorm. Also, just wanted to highlight the fact that Ronica's book is available today at the register. And we didn't talk about it, but hopefully Ronica would be willing to sign some.
Yes.
Yay, okay, great.
You don't need my signature, but.
You don't need it, but it might be nice.
Yeah.
So without further ado, I'm going to go ahead and pass off. We do have an audience remotely joining us as well today. So we are going to ask the folks on the panel to repeat any questions from the audience into the microphone for the benefit of folks who aren't in the room. But thank you all so much for being here. I'll let you individually introduce yourself. And thank you so much to everybody who turned out in the middle of this rainstorm.
Hello, everyone.
Hello, everyone. Thanks for coming out, really. It's raining quite badly. Beautifully, I mean, actually, I love the rain. My name is Domino. I'm a member of Appalachian Medical Solidarity. It's a collective that is comprised of like street medics and paramedics and some nurses. And we've been around actually since 2003, 2004. Many different names, many different iterations, primarily operating in the Southeast, this region of Appalachia. And we really focus on both hosting trainings, but also we're currently building up like a regional support network to help other people in this region also have medic training, specifically like 20-hour street medic trainings. And we, maybe a lot of y'all are familiar with us, especially post Helene, but we're also we're responding to the day-to-day drudgery of just daily medical needs. Like if somebody needs we find out someone needs a walker, or someone needs some piece of medical equipment that we have, because we actually have a hub, we will just deliver it to whoever we learn about in community. And also we are ready to respond to crises, both locally and helping out other people, specifically disaster relief related crises, also regionally. And so we send out supplies to other people dealing with disaster relief stuff too. And we're just really interested in building dual power. You know, we're not just doing this to like kind of do the kind of hemorrhaging, like stopping the bleed of people's immediate needs now, but we also want to build alternative models. So right now, people don't have to engage with the sometimes only possibilities that they think exist, but also for the future that we want to see, where a lot of these institutions maybe don't exist at all or look radically different. We are also trying to help skill up for that day.
Hey everyone, my name is Julie. I work with the Asheville Community Bail Fund. Really appreciative to be here with Ronica and AMS today. I'm just going to talk a little bit about the bail fund. So if you're familiar with the idea of a community bail fund, we come from an abolitionist framework and we bail people out of jail. Bail is basically in my opinion, in our framing, another word for ransom. It's a price that is put on the head of people who are arrested pre-trial. And if you have money, you can get out. And if you don't have money, you can't get out. It has nothing to do with public safety. It is simply the creation of a two-tiered system in which people with money are able to, leave the jail and dispose their case from outside, and those who don't have money do not. So coming from that perspective, we're all volunteers. We're a small but sizable collective of really dedicated folks who are raising money, leveraging the funds, the mutual aid from the community to then post bail for people so that they do not have to go through the predatory private cash bail industry. Obviously, we would love to see the end of cash bail entirely. That's something that I think you'll read about in the book and that Ronica might talk about. But kind of pending that reform or change to our system, which it bears noting that the United States is one of the only 2 or 3 countries in the world that have a for-profit cash bail system. So it's not inevitable. It's quite unique, but it is extremely, extremely damaging to people and communities. So in terms of kind of like the size of our impact, so we bail people out of the Buncombe County Detention Center only. So we're serving one county, which is pretty common for bail funds. And we have, just to give you a sense of it, we've had about 90 requests for bail this year alone. And we've been able to bail out about 17 people. So about 3 people a month. So, we're not able to meet the full need by any means for bail, but we are, kind of making that direct impact for a significant number of people. And recently, or over the past year, we've tried to meet some additional needs through doing commissary and jail visitation. So that for people who are still in the detention center who were not able to bail out, we're able to do something to support those folks as well. And that's been very important. We've gotten a lot of feedback that those commissary drops and jail visits are meaningful and, you know, materially substantial for people inside. One thing that I wanted to touch on because it overlaps really well with the book is that I learned in the book that the American Public Health Association had put out like a abolitionist minded or informed framework of policy suggestions. And the very first recommendation is to end cash bail. So I think the echoes are really clear that, you know, inherently what we're doing is, yes, it's abolitionist, yes, it's decarceral, but it's also about public health, right? These issues are tied. And another thing they talk about in that same chapter is the fact that when you look at the folks who community bail funds, not just here, but like nationwide, bail out, there's a really, really low percentage of people who actually end up, people who are bailed out by community bail funds end up actually getting convicted. Like, I think it was like the Bronx Community Bail Fund was like 2%. And that's actually really, really key because that is a major part of why the system works the way it does. It's not just incidental, it is necessary for our carceral system to keep functioning, to coerce plea bargains out of people by keeping them inside while they are in pretrial detention. So that is something that community bail funds are doing, even if they're not able to bail everyone out. Everyone who they're getting out is someone who is like messing up the statistics of the criminal justice system. And one of the reasons that I wanted to share that is because of like an anecdote from our experience. We often find ourselves talking to public defenders and court-appointed attorneys. And I was talking to one guy, and he was kind of giving us credit and saying, you know, you're 2 for 2, you've bailed out a couple of my clients, and, you know, it's been a good experience for him as an attorney. Notably, both of those clients were Black men who would have been, you know, waiting for months and years inside. At this point, one of them had, you know, their initial arrest had been like a couple of years before. So if we hadn't bailed him out, he could have just been in the detention center pre-trial for like years. And I commented, you know, just kind of like an aside of, oh, that's crazy that the jail system, you know, and the county apparatus wouldn't care about these people just being inside for all that time if we hadn't bailed them out. And he corrected me and he was like, oh no, they care. They're pissed about it. Like they want those people in there. And he said, because he's a court-appointed defender now, but he said, I was in the prosecutor's office for over a decade, and that's exactly what we did. That's how we did what we did, was we wanted people to plead out, and they're not happy when people leave pre-trial. So yeah, that's our context. And another piece of our context locally is that we, for a time, maybe not now, but back in 2022, Buncombe County Detention Center was statistically the state's deadliest jail. And notably, the deaths that occurred around that in the period, they were not from like use of force. They were all overdoses or medical neglect or suicides. Like they were all related, again, to these public health and, you know, mental health issues that are obviously not being taken care of outside of the detention center. And then they are only being exacerbated and ignored once someone is actually inside. So that's something that we've seen. We've seen people go in and on minor charges like trespassing, and then suddenly they have a major charge for basically an emotional outburst or having some kind of mental deterioration that leads them to do something inside, allegedly, that gets them more charges. So it's clear that that environment is just part of a cycle of kind of like victimization and deterioration that doesn't make any sense. Okay, I just have to say this last thing because this is my thing that I always have to talk about. Is it okay? So all of this is bad enough, but it's particularly galling when you're in an area like ours where there is this kind of like facade of progressivism. There's a lot of hypocrisy, and not just at the level of like narratives. So like there's this narrative that we have this progressive sheriff and we have this progressive county, and we have gotten millions of dollars from the Vera Institute Foundation, which folks may be familiar with. It's like this supposedly progressive criminal justice reform organization, does a lot of grant making. This county has received almost $5 million over years from the Vera Institute, specifically to decrease our jail population and reduce our racial disparities. And over those years, you know what $5 million buys you? A 6% increase in our jail population and no measurable impact on racial disparities at all. And if you're interested to know more about this data, you can actually go on the Buncombe County website and look at these like transparency dashboards. I think maybe that's what the money went for, was like just building the dashboards probably. So, you know, there's on the one side, the county is getting millions of dollars to implement this reform that they're simply not carrying out. At the same time as they're doing that, on one side, the narratives and the actual resources going toward policing just keep going up and up. So there's a disjoint there. And that's why like abolition is the only way, because these criminal justice reform initiatives, first of all, they're not enough to like remake the society that we need, but also they're not doing them. That's it.
So sorry. Now the mic is on. It's really an honor to be here with both Domino and Julie. It's really nice to be grounded in what's happening here, because I'm not from here. I came from Brooklyn, which is really like, I haven't spent a lot of time in the South, and probably have some stereotypes that are unfair about the South, if I'm perfectly honest. But maybe good things I should say about myself. I've worked in medicine for a really long time. I started as an acupuncturist 23 years ago. I've been a family nurse practitioner for 17, 18 years. I've been a psychiatric nurse practitioner for 3 years. And I've worked in a lot of different places. And here's the thing, I assume that all of you understand abolition better than I do. And I assume that most people who don't work in healthcare understand abolition better than people who work in healthcare, because so much of healthcare is intertwined with carceral systems that we don't even notice how intertwined it is. And we sort of like take it for granted that we have to do these carceral things all the time. And as someone who really didn't benefit from medical systems as a kid and as an adult, it really became like, even now, like, I'm not going to get a pap smear from anyone. Like, I don't trust no one to be down there, right? Like, and I don't think I'm the only one in this room who feels that way. And so why are we so untrustworthy? Why are clinical systems so untrustworthy? Why is it that, like, you know, you take care of one fat person and don't treat them badly, and then all of a sudden you're on the listserv and everyone is like, you are the person that every fat person should go to because you don't fat shame people? That's really pathetic. That like the rest of medicine thinks that we should treat people's bodies as if there's constantly something wrong with them. So that, I also think it's very clear that empire requires prisons, and that prisons extract labor and create injury. Borders make some labor more valuable than other labor and create injury and death. And that borders, you know, a lot of the original borders between US and Mexico, Harsha Walia talks about this in her book, Border and Rule. If you haven't read it, please read it. That borders were largely constructed to stop enslaved people from running away. And, you know, there's a history of this in Mexico. I lived in Mexico and ran a refugee clinic on the border for 4 years. And there's all of this like Black history in Mexico as a result of people who ran away from slavers. And so much of it is about the subjugation of people. So much of how we have constructed systems, including medical systems, is about subjugation of bodies and populations, and made to codify that white, cisgender, heterosexual men are the most perfect specimen that exists. And I think we all know that's true, but I think we could do better, and it's important for us too. Okay, that's enough about me. Okay, so I'm going to represent one of the things I was really excited about in this book is that I worked with a lot of artists. There's 36 pages of art in the book. I tried for more, and it's all in black and white. I tried for color. And that was such a pleasure to me because I'm not that great of a reader, if I'm perfectly honest. Like, I get distracted. I want to do other things. You know, eat. It's hard to eat or like cook food and read at the same time. But this was one of the artists whose artist name is Killjoy. And Killjoy is an artist whose work sits at the intersection where jungle meets desert. Her art practice interprets world mythology and ancient symbolism to highlight issues of environmental and social justice. And this, we worked on the piece together, and it was really because I feel like oftentimes when we talk about abolition, we talk about prisons only, first of all. And we really talk about it as a racialized issue, which of course it is. There's no doubt about that. But it is also a queer issue. It is also an issue of the genocide of Native Americans. It is also an issue of disability. It is so many kinds of issues. And we should be able to be that complex in our thinking because that is who makes up our world. And so Killjoy and I worked on this piece, and I was like, the other page was like basically all of the systematic exclusions that have happened for Indigenous people in this country. And then she was like, I can't just make a negative piece. And I was like, that's interesting. I could. But then she made this like sort of answer piece that was about the things that should happen, she wants to happen in the world, or specifically for Indigenous sovereignty. Let's talk a little bit about the state of things right now. This is a piece by Fritz Zufos Aragon, born in Manila, Philippines in 1975. Since 2014, he has operated Urge Palette Art Supplies Paint Sugar Gallery, located in downtown Riverside, California. In this beautiful piece, he writes, due to the indecipherable maze of immigration restrictions, sick and disabled migrants are denied needed medical care from the court system, despite clearly qualifying for humanitarian parole from their medical conditions. I'm going to read because you came to a book reading, so I don't know what you thought was going to happen. And so I'm going to read other people's words. These are not my words. So this is this first section I'm going to read is from Mihir Chaudhry, who is a trauma surgeon fellow at Grady Memorial Hospital in Atlanta, and a researcher on policing, the carceral state, and violence. And he does a bunch of different things, works in a lot of different disciplines. With few exceptions, police authority is widely accepted at Highland Hospital, which is in Oakland, California. That's where he was, including during trauma activations. Throughout my 2 months as a senior resident on trauma, that is, as the trauma chief, there were many instances of police entering the trauma bay to seek photographs of patients for evidence. And there was only one case where they were asked to leave during an acute phase of resuscitation by a nurse. Generally, residents would defer to perceived police authority, allowing them to seek whatever evidence or information they needed from patients, because that is often what happens in hospitals, that people cooperate with police, even during time-sensitive or critical junctures in care. One such instance involved a young Black man with a gunshot wound to the left upper arm, suffering a brachial artery branch injury with ongoing blood loss. The patient's injury mandated an urgent operation. However, 2 officers stalled his transport to the operating room so they could have the wound dressings removed and have pictures taken. While these actions were not in keeping with hospital policies, which prioritized the immediate care of the injured patient, the police acted with de facto authority to delay the treatment for evidence capture. He also writes, the distribution of violent injury is racially inequitable. While homicide is the 3rd leading cause of death for young Americans aged 15 to 34, it is the leading cause of death among Black Americans in this age group, according to the CDC's findings in 2021. Also, according to the CDC national database, which we're losing. I mean, not that I was like, oh, I love the CDC so much, but like, and it's like, it's a fucking slippery slope of it's better than nothing, honestly. But like, also now we have fucking no data about this shit. We have no data about police killings at all. And many states did not cooperate with that at all. Or police related injuries, or deaths in jails. Many states did not cooperate, only 12 states did. But we don't have that data from the MMWR, which is the Morbidity and Mortality Weekly Report. So, is data the answer to oppression? No. And like, as we work towards abolition, we need to also make people's lives better, right? And sometimes data can help that. Anyway, shut up, Ronica. Also, according to the CDC national database for the year 2015, the first year for which race disaggregated data is available, Black Americans sustained over 400,000 non-fatal injuries out of the total 2.16 million non-fatal violent injuries. This represents twice the rate of non-fatal violent injuries sustained by white Americans in 2015. He also talks about HIPAA and EMTALA, which you are probably familiar with HIPAA. Who's familiar with EMTALA? Yeah, okay, cool. Anybody want to talk about it? Well, no, I'll read his words. I won't force you to be on that. So it's really about the intertwining of carceral and clinical systems from an administrative perspective, this section. So EMTALA sets a limit of law enforcement personnel involvement during the course of patient care. In general, EMTALA limits the ability of law enforcement to obtain tests from the hospital, such as blood alcohol level and imaging studies to localize bullets solely for evidentiary use. Once patients arrive in the hospital setting, the clinicians are responsible for their care and not beholden to and generally not advised to perform labs or studies for legal purposes. However, when certain tests are performed for indicated clinical care, law enforcement personnel may use the collected data for evidentiary purposes without a warrant. And it's interesting because there's not a lot of specific like state-based or federal laws about how you can collect this kind of data from patients. And sometimes hospital will have policies, but it's almost like it's a floor-based moral code that people have decided to build together that's almost always steeped in racism. Like it's like, do people get random urine drug tests? Oh, it just so happens that it happened to be Black people that got random urine drug tests more than anybody else, right? And so I think what he's pointing to also is that the way that policies are enforced or not enforced has to do with the way that we have racialized medical care to benefit the dominant majority. This is a piece by Edie Elena Davis. Do you all know Edie? Oh, you're familiar with the comic. Yeah, okay. So Edie, I got in contact with Edie from ABO Comics, which if you don't know ABO Comics, I really recommend knowing them. They're fucking amazing. We did an event actually in Oakland at their office, but ABO Comics is this queer trans prisoner comics group. And they also, I mean, Casper's just like, I don't know, such a fucking badass. Like they basically have set themselves up to be a publisher in all 50 states so they can get books into any prison, including this abolitionist book. Like every prisoner obviously got a copy of of the, well, maybe it's not obvious because it does say abolition on the front cover of the book. So I wasn't sure if that was going to happen, but they can get anything into any prison. And they also collected all this art. They have all this art, and we used it and put it in the book from queer and trans prisoners. But Edie Elena Davis died during the making of this book. And I really wanted a picture of her in this presentation. And so I kind of chased a few people to like get to a friend of hers that had an old picture. And they were like, I'm sad that I don't have a picture of her kind of later in her transition. And I was like, well, how would you like the audience to imagine her? And the friend said, if you could ask the audience to like imagine her wearing something pink and her hair longer, I think she would like that. So I think we can all do that. So this is her comic. I will read it to you. Don't you worry. I'm not coming at you complaining. Here, hopefully, to give insights as to the realities of being a trans female illegally and unconstitutionally held within Texas Department of Criminal Justice Institutional Division. First and foremost, there are quite a number of us in the state assigned and housed within the male cisgendered general prison population, forced to live in cells with a cisgendered male, where we were given only a pair of men's boxer underwear to sleep in. We are not given a nightgown or nightshirt to sleep in, nothing to cover or conceal our breasts with. We are required to adhere to male cisgendered grooming and dress policies, which are considered the normal men's standards here in the South, in the heart of the slavery and prejudices. When we fail to comply with stated grooming and dress policies, we receive discipline, write-ups, and possible loss of privileges, restrictions, where we are denied possession of our personal belongings, so compliance with the normal men's grooming and dress policies forced upon us in spite of our feminine identities. I'm going to skip ahead. Even though all the administrative and departmental authorities state claim that there is a zero tolerance policy in the Texas Department of Criminal Justice Institutional Division in accordance with the Prison Rape Elimination laws, Elimination Act laws set forth by the government, which include the criminal acts of unconsented, unwanted voyeurism. In spite of this falsely touted claim of zero tolerance policy, they constantly and continually lock us in cells with cisgender males where we have no nightly sleepwear to cover or conceal our breasts from full view of the male in these cells with us. I'll stop there on this page. She goes on to talk about how, some of the rights that trans women should be granted. She says trans females, I'm using her language, but I will use trans women from my language. And she says, I'll end, she talks about Cece McDonald, about whom she says, Cece McDonald once said, you can still be cute and wear talons and be an abolitionist. I don't know her, and I see her as one more of my many sisters. I really loved that. This is Ronald Leftwich. Ronald Leftwich is prisoner and restorative justice activist he's been incarcerated since 2014. And in 2020, he became a member of the restorative justice planning team, and he's now the coordinator. And we're actually going to do an event for the book inside of the prison in Massachusetts, which I'm really excited about. We're having a phone call. Today's Saturday, the next week coming up, so we can kind of plan it. And I'm very curious about it. Like, I'm so curious how this person who is a prisoner has enough power to be able to organize an event within his prison. People really manage to do that, or they don't. And that's why prisons are so fucked up, because it shouldn't be arbitrary that people get to have more autonomy within their settings. In this chapter, I argue that is the failure of the state to recognize and treat the trauma that precedes violence, which honestly, like, if we're not talking about trauma, there's a real fucking problem. There is no liberation without acknowledging the traumas that we've experienced and are constantly experiencing now. which denies us real safety and keeps us locked in perpetual cycles of violence. The connection between trauma experienced, trauma left untreated, and violence committed toward people in the carceral system becomes evident as I detail the traumatic, dark past of my personal life. If, as I assert, trauma is at the root of violence, we must abolish the current system, which neither recognizes nor is designed to treat the trauma in our communities. Finally, I argue that the only way to truly achieve safety is by completely dismantling or abolishing the carceral system. In its place, I propose restorative justice and abolitionist principles as the transformative foundations for communities of care. Communities supported by restorative justice principles begin with the premise that everybody matters. So when harm is committed, the entire community has a stake in the outcome. He also says, abolition is about changing the ways we currently respond to harm without creating more. Our courts, prisons, and jails create more harm by resting on a system of retributive justice that continues cycles of violence. While abolitionists is concerned with abolishing prisons and jails, this is not all it is concerned with. Abolitionist principles also begin with the idea that everybody matters, everyone matters, and no one is expendable. Through abolitionist understanding, we don't put people to death or incarcerate people forever to solve our problems. In communities of care where restorative justice and abolitionist principles are the norm, violence is viewed from a perspective of health, and the current retributive form of justice is skewed in favor of a system characterized by healing, restoration, dialogue, and truth telling. And then a little bit about his story. He talks about his story, which, you know, he really begins with his father who was in the Korean War, and how the violence that his father experienced in war really shaped him as a parent. I was 5 years old when I witnessed the shooting death of my father at the hands of my 13-year-old brother, his eldest son. I know now that it didn't have to be this way. His was one of the first pieces that came in when we put out the call for pieces. And I remember reading it and just like crying and being like, wow, this is really pathetic. Like, you are crying and this person is actually stuck in a fucking prison. But we did a really fucking good job. He got me. He got the eyes. Okay, so this is one of my best friends, E.T. Russian, is a disability justice activist, who drew this piece, which was an interview between Juliet McMullen. It's a podcast, actually. I really recommend it. Juliet McMullen, who is a cultural and medical anthropologist, interviewing Delight Satter, who is an elder and tribal member of the Confederated Tribes of Grand Ronde, Oregon, and a senior health scientist in the Office for Tribal Affairs and Strategic Alliances at the CDC. But, you know, yes, is it a complicated role? Absolutely. And I think some of the information that she puts out is really worth thinking about and learning from. You may say, why Native health as a focus? Because I think one of the things that most Americans don't know about is how discretionary funding affects BIA health services, and that 50% of all health funding, it's about 50% of all health funding on like tribal reservation land is what's the word I was looking for? Discretionary. Thank you. I just used it. Done too many drugs. This is the problem. Anyway, so discretionary funding, and that number really hasn't gone up in relationship to how much healthcare services cost, which is part of the reason that people can't get the health services they need. Okay, so Juliet asks Delight, Miakswe Delight, could you help me think about the high rates of chronic diseases doctors witness when they work in Indian health clinics? Delight, yes. Native patient populations do have high risk compared to other populations. It's important to view these rates in the context of intentional US policies of ethnocide and genocide and the experiences of Indigenous people. The killing and removal of Indigenous people from the land, forcing them to live on reservations, and the stealing of Indigenous children, forcing them into boarding schools, this all disrupted family, economy, and subsistence. Programs that claim to help Indigenous people are developed, yet the resources often often never make their way to the tribes or individuals. This all has an impact. Native populations experience something called weathering. The experience, which is telomeric, it has to do really with these caps that are on the ends of your, like chromosomes, genetic material. And when they fray, you have less viable cell division over time, which is how weathering is thought about. The experiences of chronic discrimination results in health effects about 10 years earlier than the white population. In the 1918 flu epidemic, many Indigenous people passed. We are missing those generations that are essential for supporting knowledge sharing and healthy lives. Doctors are seeing echoes of the policies that were designed for genocide and ethnocide, not to mention the ongoing aggressions we see today. So in carceral context, we know health disparities and carceral involvement are deeply linked. Native people are incarcerated in state and federal prisons at a rate of 763 per 100,000, which is double the national rate and more than 4 times higher than the state and federal prison incarceration rate of white people. Okay, this is my friend Cleo. And Cleo is a tattoo artist, just kind of an amazing person. And they're an illustrator living in San Francisco, California. And, in their past, they've had 5150s called on them, which is when you are involuntarily psychiatrically hospitalized. And so they detail that experience from somebody else's perspective. The policing of psychiatric care. A shaved-headed man with a t-shirt, no pants, and a bottle in his hands yells, "Leave me alone." Passerby. 911, what's your emergency? Person on the phone. There's a man talking to himself. He's naked. He seems upset. When you call 911 on someone in psychiatric distress, the shaved-headed man, they put a microchip in my medications. There's a good chance that the police will show up before paramedics or social workers. This creates a very dangerous situation for the person in distress. Shaved-headed man, please, I don't want them to know where I am. Paramedics will hang back just in case it's a psychiatric hold. Police officer, can you tell me what day it is? Shaved-headed man, are you working for Trump? While armed police approach, the answer is yes. While armed police approach a vulnerable person, the fact is 1 in 5 people killed by police in the US experience mental illness. Police officer, what drugs did you take? Shaved-headed man, Trump and this judge I had a crush on are tormenting me. If there's something you could do so I'm somehow protected. 2 police officers physically restraining the man. Cops out of mental health crisis response. Again, illustrating why police are not, they're not the answer. That's like a period. And they're certainly not the answer to a drug or mental health crisis. This is art by Glenn Kanoko Tucker. And Glenn Kanoko Tucker, this is their bio, is still figuring out how to identify themselves. However, their recent acquisition of gender fluidity helped them gain insight into their feminine spirit. Art started for Kanoko consciously as a child. It became a safe place to explore their sense of wonder, curiosity, and sacredness. So let's talk a little bit about the work of Naomi Schoenfeld and Jennifer Steen, who I got to be on a panel with, alongside the person who wrote the APHA abolitionist article, just like very brilliant people. So Naomi Schoenfeld is a medical anthropologist and nurse practitioner in San Francisco. On the left, on the right is Jen Esteem, who was really interesting because she's like a lot of things. She's a registered nurse, mother, and community leader, but she also like ran for office under like an abolitionist platform in San Francisco. Did she win? But anyway, the fact that she ran under abolitionist platform, I was like, you're an impressive person. So they talk about crisis. And I really appreciate talking about this in healthcare because I feel like most healthcare workers don't think it's unless they're an ER person, don't think it's their job to deal with crisis. Even though the person showing up is very likely in crisis. They don't feel well, something hurts, their blood sugar is this, their heart is doing this. And somehow we're like, we should be untouched. by this thing, right? And when people are in crisis, what do people in healthcare do? We call the cops. We call security. You know, why do 97% of all hospitals have armed police officers in them? It's just an atrocious fact. Okay. The term and concept of crisis appears frequently in healthcare and social services. An estimated 20% of 911 calls are initiated in response to situations involving the behavior of an individual presumed to be related to underlying mental health or substance use. When these behaviors occur in public spaces, they're often taken to constitute a crisis. One of many atrocities of racist policing of Black and Brown communities includes violence against and murder of individuals and families in the midst of what is often described as a mental health crisis. This can include the murder of a person in crisis who dialed an emergency number or whose family dialed an emergency number. Increasing evidence reveals a disproportionate number of 911 calls made in response to these types of crises end in the police murder, killing of the individual experiencing symptoms of distress, following the same patterns of racialized policing targeting Black and Brown communities. Mario Woods, Micaiah Bryant, Daniel Prude, Sonia Massey are but a few recent examples of police murdering a Black individual in distress. Later in the chapter, San Francisco street crisis programs work closely with other clinics and centers charged with providing crisis care, including EDs, urgent care centers, and even alcohol sobering center. The teams are typically activated for people experiencing symptoms associated with SMI, which is serious mental illness, or the effects of significant intoxication with alcohol or drugs. More often, the range is between psychosis and intoxication. Often both are present and difficult to distinguish. Services include dropping off clients, following up on existing clients, or finding new ones. Sometimes it involves a lot of driving around and waiting for things to happen, kind of what you were talking about, Domino, where you're like, a lot of it's really boring. And, you know, it's like gauze, you know. It often involves complex coordination between systems of care and services, de-escalation, and creative problem solving when it works well. I did an interview with Liat Ben Moshe, which, like, go persistence on my part, because I had to email her 14 times before she responded to me. And I regret nothing. So Liat Ben Moshe is an activist scholar, assistant professor of criminology, law, and justice at the University of Illinois in Chicago, co-editor of Disability Incarcerated, and also this book, Decarcerating Disability. If you do not know her, she is so brilliant and a very accessible writer and very worth reading. Like, I really love her work. So I interviewed her, total brain crush. People don't understand that psychiatrization is a carceral modality. Carceral sanism is a belief system and also a practice that builds on the idea that people with disabilities need special or extra protections. In terms of carceral sanism and ableism, it means to protect people with disabilities in ways that often lead to their marginalization and further incarceration. Sometimes even abolitionists, including prison abolitionists, who are saying that we got to get people with mental health differences out of solitary confinement, are part of carceral sanism. That has been a big, big battle of abolitionists and reformers and policy people. It is this process of chipping away at the system, because at the very least, we know that solitary confinement is very harmful for people's mental health. So these abolitionists may defer and say that the very least we could do is not put people with mental health differences or people who experience psychotic breaks or people who are suicidal, at least in solitary confinement. And it's a harm reduction approach. However, why this is really carceral sanism and not actual abolition is that, first of all, chipping away at the system doesn't get to the core of the system. When you play with the margins, the core does not fall. What it does is justify the incarceration of other people in solitary. This construction purports that solitary can't be used for people with mental health differences, but then it means that other people can or should be in solitary, just not these people. So it becomes carceral sanism exactly for a mechanism, solitary confinement, that, by the way, makes people crazy. It is an ableism mechanism on its own, but saying that we just can't put particular people like our people in there, to me, that is not disability activism. That is, of course, not disability justice. I don't even think it's disability ever anything. It's not liberatory. And yes, getting anybody out is better than getting nobody out. But I don't think getting people out of solitary is the same as getting them out of prisons. That's what I mean by carceral sanism and carceral ableism. We end up with these things as our solutions or alternatives. Like, instead of putting people in solitary confinement, we'll put them in a psych ward on psych watch in the prison. Or maybe we get them out of the prison with them in a psych facility as an alternative. And people think that that's somehow better. Like that psych confinement is somehow not confinement. I don't know what people think, honestly. If you think I edited Liat, no, she speaks in full paragraphs. Like, it's really, I did nothing, just wrote it down. I actually want to say one other thing that she talks about. I guess I didn't put it in here. Okay, never mind. So what is abolitionist health justice? Abolitionism, abolition, the eradication, that political vision of eradicating prisons, borders, policing, detention, surveillance, and creating lasting alternatives to punishment, deportation, incarceration. Abolitionist health justice is this grounding framework that sees carceral systems as the root of many health inequities and focuses on removing barriers, including carceral ones, to healthcare in order to improve health outcomes for actually all people. So let's talk about these things a little bit from a few different perspectives: medical, mental health, community health, and I'll just give you some examples. I'm a very, unfortunately, data-driven person, and so I like the data because it just reifies who I am. But let's talk about, how policing affects communities of color. We know, I talked about those telomeres, those caps, and on our DNA that are associated with cell division. And we know that shortening of telomeres is associated with cellular aging. And so McFarland et al. Looked at this study on accelerated aging, and they found accelerated aging as a result of indirect or direct unfair treatment by police, particularly for Black men, targeting Black people in community. And here's the thing: white people in that community did not have shortened telomeres. Okay, so it is a racialized issue, right? White people are not affected by racism. That's just the end of that sentence. And then similarly for Indigenous populations, we talked about that shortened telomere length too. There's a lot of studies like this all over the world, and I think they are really interesting because also in 2025, people are obsessed with living forever, right? And they're do I take metformin, or do I take these 16 different medications so I can live until I'm 1,000 years old? And I'm like, okay, maybe if we got rid of police, you would live longer. Anyway, and then in terms of thinking about infectious diseases, the impact of prisons and carcerality, we know that HIV prevalence is 3 times higher in incarcerated individuals more than the general population. And what is not known is whether or not that happens before, during, or after, that predisposition or the likelihood increases as a result. It's really the whole fucking process, right? It's the process of being targeted, experiencing these health disparities that then lead to incarceration that also show up in these populations as an HIV disparity. We also know that people are imprisoned for their HIV status in this country as our HIV funding is being cut from the federal government. We know that people are imprisoned for that. And that recent incarceration is associated with an 81% increase in HIV risk. And what's also interesting is that, like, I think there's this idea that parole and probation are like incarceration light. Like, it's just like you also get like a little bit of a shoulder massage while you're under the cultural eye or something. But what we know also is that the crude mortality of probationers and parolees exceeds that of state prisoners and jail inmates and prisoners in every single state that it has been studied. So it is the carceral gaze, and that is because of many things, including the inability to achieve employment, right, and just access to so many kinds of resources. Yeah, same. And then let's talk about this from a mental health perspective. We also know that police killings of unarmed Black Americans increase and are as deeply connected with poor mental health outcomes, including increased poor mental health days. And, you know, there's this other side of chronic disease where most people who have chronic diseases also have poor mental health times and days as a result of dealing with their mental health. Well, that's how much police violence increases poor mental health in communities and in people who have not actually even been directly affected, but know the effects of police violence in their communities, specifically among Black people. And, you know, just to reiterate, police killings of unarmed Blacks did not impact the mental health of white Americans. Prisons. More than 70% of people in US jails and prisons have an inadequately addressed mental health diagnosis. And incarceration is independently associated with post-traumatic stress disorder, depression, anxiety. Like there's not very many mental health diagnoses that are not associated. Like there's also this idea that people in prisons have more personality disorders than people outside of prisons. But then there isn't this language of people develop personality disorders as a result of trauma. So if we're going to say that, then you got to say the beginning part of where it started from in the first place. And how do we alleviate that? And then, you know, I talked about the piece by Naomi Schoenfeld and the work that they do in Jennifer Steen. Mandatory reporting. How many people in this room are mandatory reporters? Yeah. Lauren, you didn't raise your hand. You are too. Yeah. So, you know, if you don't know what mandatory reporting is, it's this legal obligation for people for specific individuals and professionals to report suspected or confirmed cases of abuse or neglect, you know, and different states have different laws. I should have looked up North Carolina before I got here, but children are always a part of mandatory reporting, but it can also be elder and it can also be people with disabilities. And we know that millions of families are disrupted by investigations that result from mandatory reporting, which is basically you're supposed to call this line in pretty much every state to report it. And that most of which does not lead to substantiation of abuse or neglect. And the thing about that is like the argument I've heard for that is, well, they're not doing a good job investigating, right? And like what's the other side of that? Anybody have any thoughts? Yeah, it's not happening. It's a racialized analysis. What someone's idea of like what should happen with a kid who's had this mandatory reporting happen to them is like pretty problematic. But we know, and like I know so many providers who work with kids who are just like, I had to mandated report this person because I just like didn't feel good about the situation. Well, fuck right off. Like you didn't feel good about the situation, bring in resources. Bring in things that are going to alleviate the fact that they don't have enough time to take care of their kids and they don't have the money to pay for childcare. If you cannot do that before you report someone, I mean, it's probably because there isn't the community network to do that. And that needs to change first, right? Before we start sending people separating families, which like we talk about family separation at the border and we should, but it's happening in this country and has happened in this country for a very, very long time. And so, yeah, I mean, you know, we know that mandatory reporting does not produce good results. We know that for the most part, things get worse. 50% much worse, 12% a little worse, and 20% no difference. And then, we know that hospitals and clinics, moving on to a new topic, hospitals and clinics are rife with violations against immigrant patients, that there have been all of these deportations. And honestly, like, we don't have those numbers now, right? Like, originally when I wrote this, it was like since 2017, it was involuntary medical repatriation, and it was about like 1,000 patients or something. I would suspect that there's been at least 1,000 this year. This, not even all of 2025. I'm talking about the, how many months? 7-ish months that we've been in. I would believe that there's been that many repatriations. I mean, we're sending people who only speak Spanish to Sudan. Like, what the fuck is happening? Anyway, you're all there with me. But in involuntary medical repatriation of undocumented patients has been the sinister step in removing barely stabilized people after major surgical procedures back to their country of origin, where appropriate subacute care may not be available. Yes, that's true, but also they might be in great danger, right? Because they left for a reason. And Trump is trying to do this shit about like third country, sending people to third countries like El Salvador, right? El Salvador's now built this big, the CCOT prison. And I mean, it is also people with severe medical issues are being sent to these prisons as well. So we know that these things are deeply sinister, and we also don't have the data to even know how much. One person is too much. I agree with that. And yet I want to know how much it's happening too. So I think for clinicians, what else is abolitionist health justice? It's understanding that clinicians were responsible for making up diagnoses like drapetomania, which many Black people were sent to psychiatric institutions for, that the construction of a lot of what we do in gynecology happened on the bodies of enslaved Black women, that we learned how to make birth control on the bodies of Puerto Rican medical students who were told they could either take those medications or they would be kicked out of medical school by the US government. So like, we have done a lot of bad, and that historical oppression has created these lives that are constantly contending with the inadequacies of our systems and the racialization and anti-trans, anti-queer, all of this stuff. And also that people are facing battles because of racialized targeting, immigration status, queerness or transness, abortion access, disability experience, mental health differences. And that we got to think about that when we're making diagnoses for people. We need to not diagnose any more children with conduct disorder. Like, that is a fucking horrible diagnosis for a kid to get. It really, a lot of kids end up in jail. If we're going to think about mandated reporting a child, we have to remember that 60% of people in men's prisons have been in the foster care system. So what are we like, what are the harms of what we are doing has always got to be at the forefront of how we do care. And we need to not police our patients, right? Like, we need to not think that police are good for people, for our communities, but also that, like, if our patients take their meds, there's a reason they don't take their meds, and it's partially our fault. Like, we just aren't good enough sometimes, and that's just the fucking reality. And we need to do a lot more introspection, and we need to ask how carceral systems are operating in our clinical care. How are they affecting our patients? How is systematic exclusion operating? How is trauma operating? And then, a little bit about thinking about New York. they did this study in New York City, which is very dense. So it's a good place to look at populations, and found that neighborhoods with these high incarceration rates also had disproportionately high rates of diabetes, psychiatric hospitalizations, people with unmet medical needs, infant mortality, early mortality. I mean, I know most of you who are not in medicine are like not surprised by this, but people in medicine are like, oh, wow, I just had no idea that these things went together. And that's what's so fucking annoying about my people. And that family and communities are often affected by repeated exposure to the trauma of incarceration, and poor communities always experience a greater burden with these traumas, with far fewer resources for dealing with the outcomes. Also, the border affects people outside the border, but it also affects the mortality of Latinx and Native people within the border. We know that people close to the border who are Native and Latinx, live an average of 2 years less Native and Latinx people throughout the United States. And that all this American safety is killing us even within the borders of the United States. I think grief is such a big part of what we hold as a result of carceral systems, if you know people who have been impacted by them, but even if you don't, because I think there is this grief of having the constant threat of your freedom being taken away. That is very, very real. Like the idea that Americans are free. My mother used to always say, you have a number. Your social security number makes you not free. And I was like, okay, fine. But so I got my driver's license. And what's that? Which also has a number, exactly. So the National Institute of Health uses Surya Nayak's words to define racial grief, which is the idea of occupying racial grief is to recognize that living within racism produces loss and grief. Racial grief is a symptom of living within the context of racism. However, rather than being busy in the work of getting rid of the grief that racism causes, an alternative idea is to be occupied or busy in the work of understanding how racial grief can be harnessed as a force for collective action directed against the multiple interconnected social injustices of racism. It's in this context that we need to consider racialized policing, just policing period, incarceration and deportation. Yeah. And I think, racial grief lives alongside and intertwined with queer grief. We know that LGBTQ people are incarcerated at triple the rate of straight people and experience systems exclusions, and that LGBTQ youth are, it depends on the study, but at least 3 times overrepresented in juvenile justice systems in this world, in this country. We know that people with disabilities, especially those from marginalized racial and ethnic groups, are more likely to be arrested, convicted, and sentenced to longer prison terms. Compared with 15% of the US general population, 40% of the prison population is disabled. Which makes it a predisposition, right? Like having a disability predisposes you to incarceration. Trans grief. We know how illegal it is to be trans in this country right now. It is illegal to use the fucking bathroom in most, I think, North Carolina, right? Yeah, we need more sanctuary places for trans people. And then obviously we need to burn the government to the ground, but that's like a slightly different story. And then immigrants are being deported. Immigrants are being deported and denied access in ways that are yet incalculable and unprecedented right now. And I talked about the Native and Latinx population living near the border. The grief of poverty, the interplay between poverty and incarceration creates a cycle where individuals face barriers to access, employment, housing, and social support, increasing the likelihood of rearrest. If we're saying that people, quote unquote, serve their time in prison, why can't people get jobs when they come out? Carceral grief. There are many ways that carceral grief exists, including the 10 times higher rates of overdose within the first year of coming out of prison, the many mental health diagnoses, including PTSD, depression, inability, and also the inability to access care. But also, so many people who've been incarcerated talk about how difficult it is to form deep relationships with people. And I'm not saying all, and I'm not saying that people talk about this with all the people in their life, but because that constant threat of carcerality makes that building deep relationships even more vulnerable. And yeah, I mean, I think that's something we all deserve to have and be able to do. That's it. Thank you. That's do you all want to come up here? And the two of you, sorry. And we can answer some questions together, or what's happening now, everybody? But does anybody have questions? Should we do some questions? Okay. I'm also okay, I'm very lone up here. No, that's okay. I'm just kidding. No, I'm kidding. I'm being silly. Yeah. You've been tricked. Yeah, does anybody have a question? I will repeat your question because there's people online. Yeah, hi.
Earlier on the slide, maybe I misread, but it said people are imprisoned for their HIV status.
Yeah. So the question is, people are imprisoned for their HIV status. So are you all familiar with the case of Michael Johnson? Anybody familiar with him? So he was in prison. He's out of prison now, but for having unprotected sex with people who knew his HIV status. And multiple people he had sex with actually testified to the fact that they knew his HIV status when they had unprotected sex with. He also had protected sex. It wasn't like he only had unprotected sex. And there are multiple cases that are currently happening for people having sex, basically, who are HIV positive. He's not the only one. He's just the most famous case. Yeah. Hi. Yeah.
Hi. So I kind of feel like the goalposts up until, this election, this past election, they weren't great to begin with. Sorry. The goalposts weren't great to begin with, right? But now I feel like especially with the big nasty bill passing and, the funding that's going to be unleashed in terms of increasing ICE capability and, all manner of, police forces, but, militias, whatever, and the military in some instances, I feel like the goalposts are being moved, and they're being moved quickly. So how can I may have been seen a news story recently about ICE going into an emergency room or a hospital. So what can communities do and organize to sort of combat this?
I'm thinking that's a big question.
It's the
Yeah,
question,
yeah,
right?
yeah,
I mean, I get it.
Yeah, I mean, I would say if you're in an area where there is actively immigrant organizing going on, trying to plug into those efforts, finding out what those communities are seeking from folks and trying to provide it. I mean, I know here we have a really robust, I think a couple of weeks ago, everyone was talking about this Ice Block app. Everyone wanted to tell me about Ice Block. I still don't really know what it is, but people would describe it to me and I'd be like, we literally have our own version of that is way more robust and actually on the ground in this community because of the incredible work that immigrant organizers have been doing over not just the last 2 or 4 or 5 years, but decades, because we've had raids in this town before. And we have networks of people who are actively going and checking out rumors of ICE presence and confirming that and then communicating it back to the community. So, I think it's an obvious answer, but like supporting the organizing that's already happening, donating to that, if that is, what you have the ability to do is one way.
I just want to go back to your question first, which is if you are interested in the HIV like prosecution stuff, Stephen Thrasher is a really good resource. He's written a lot of books about HIV decriminalization. And I did a very bad job answering that question. So I would like to give it to somebody who's better at that. But so I also think we have to think beyond our communities, because where do people go when ICE starts to occupy our communities too? Like, we need to be building these networks and sort of creating them strategically so we can hide people and protect people. I didn't go to this burlesque show that was happening in LA, but basically they were paying people who do street vending to stay home so that they wouldn't be caught by ICE. And I think that is such a wise way. Like, how can we avoid the situations that make you the most vulnerable? And I think that means also, yes, if we're going to increase telehealth, also increase people. Most people have a smartphone, but also putting smartphones in people's hands, so that they can actually access those kind of resources. And I think it means I look at this from a clinician perspective, us just like going where people are and offering ourselves as resources. We make enough money, like I make enough money. I don't need to always get paid for every piece of knowledge I have in my brain. It's really like, why do we value ourselves in relationship to capital? And so I think that is part of the work too. Most of us have malpractice insurance. It covers us to do care for anyone we want to do care for. So but I also think it means thinking about your own, like, what do you work in and how does ICE come in there? How do carceral systems come in there? And how can you create sanctuary within it? I don't know what your specific context is, but I think that we need to like be strategizing on all these levels for sure.
That I thought of. Do you want to say anything, Domino? No. Okay. Also, I think that counter recruitment should be a big priority right now, because like, yes, they just got a lot of money for this stuff, but we don't need to treat that as like a fait accompli. We saw after 2020 that, the number of cops went way down and they've really had trouble bouncing back from that. Are they going to manage to get people who are willing to do this job? Yes, but we can actually intervene in that. Like, the messaging should be like, don't take that job, quit your job, so I think that social pressure is often not thought of as like an actual, like, social capital is capital, and it should be utilized more strongly as a strategy, I think.
Sometimes I get too galaxy brained or too micro zoomed in, and I don't actually know if I'm answering the question, but it feels relevant to me. One thing that I wish I saw people do more is just getting in the habit of stopping when they see cops pulling someone over or talking to someone, and really maybe having to rearrange your whole day. And honestly, I have a lot of friends that do not work in like, I have a lot of friends who don't have kids. I have a lot of friends who don't have some job that they like put up. Like, a lot of people are baristas. And I'm like, maybe you lose your fucking job. Maybe you actually are late to work because you had to pull over because you wanted to watch, whether you tried to talk to the person who was being bothered by the cops or you just sat and watched and wait. Like, maybe you can risk losing your barista job. You know what I mean? Like, really restructuring priorities and just getting in the habit of stopping and watching. It's past 10 years plus, probably people have really been like pulling out their cell phones and thinking that does something when I'm not saying just be a passive bystander, but just, I think a lot of people, it's better to honestly practice just talking to strangers in general, but practice like letting the cops know that they're being watched. Just the other day, the cops tackled a woman, a homeless woman. And so I pulled over and she had a bag of M&Ms that she stole from a store, you know? And the way he treated her, and this does not always happen, but the way that he treated her, once he realized people were watching, oh, do you need some water? Oh, let me help. You know what I mean? Doesn't always happen. People are total pieces of shit sometimes and they won't change. They don't give a fuck. But just, this is for cops, ICE, whatever. Like, just practice in your everyday life. You know, I don't know. Just, yeah, being a witness. It's recorded, so I don't really want to say anything more about engagement, but you know, okay.
Well, you're sort of intervening, but in a more passive way, right?
Yeah.
There's an aspect of intervention in that, yeah.
Yeah, maybe not always passive.
Yeah, right.
I mean, I think what you're asking is like the question in a lot of ways. Like, I think you're asking the question of like everything, which is why it feels hard to answer, because it is I think we need to be a web. And how do we do that when we create so much fracturing within our own movements? You know, like there's just so much posturing and the academization, I don't know what that word is, of things, and like all of this shit that we have done to separate ourselves from one another is also part of the problem. And the lack of acknowledgement of our own traumas, I think, is also part of the problem. Because how do we treat other people's without acknowledging and dealing with our own too? Yeah. Hi. Yeah. Yeah.
How do we as a community build, like, share our knowledge? Like, sorry, my wheelchair got stolen, and it took me 6 months to get my first to get me a wheelchair, and they were only getting me a wheelchair that I could fit in because I'm short and fat and wider. And so I had to buy this wheelchair out of pocket that I bought directly from the warehouse. But like, I want people to know that like, if your insurance is fucking messing around with you and not letting you get stuff that you can't buy it like consumer, and this actually before, and I had to pay this winter. So I couldn't block it. So just what are ways that we can tell ourselves to take for our personal health, and how do we disseminate that?
I mean, the only reason that your medical records should ever be revealed to, I mean, I don't even agree with this, but like to the police is if you threaten homicide or threaten to kill yourself. Like that's really the only legal reason that I know of. And even like, I've never had my medical records. That's not true. I have, but not when I was their primary provider subpoenaed. But I don't know what to do after the fact. I mean, now they have it, but I think you have to have that conversation with your providers and clinical systems too. You can have that conversation. What is your policy? And, you know, the problem is that many people, clinicians won't even see people with disabilities who are in a wheelchair. This is part of the other fucking problem. Exactly. Yeah. Yeah. All of the accessibility stuff too. But I mean, I don't know how to say how do we stop it except for the fact that it shouldn't be happening in the first place. You can't stop an individual, unfortunately, from revealing someone's medical records. That's the fucking problem with medicine, is that people will do that. Any other clinicians want to respond to that? Yeah. Okay. Oh, I didn't know that. That the court can subpoena medical records, but it has to come from the court. Did I get that? Yeah. But it doesn't have to be related to homicide or suicide. Abuse. Yeah. Yeah. It could be related to abuse too. That's true. But from what I know, and please speak to this because this is not, and maybe the laws are different state to state. Actually, do you know if that's true? Okay. Right. You have to sign a release of information form. Can have your medical records subpoenaed. Yeah. Accidental reveals and the ER information. Yes. Yeah. And sometimes the police will look at people's personal things in the emergency room, especially. And yeah. Yes, Lauren. Kind of related. They found themselves being more vague in their charting to protect patients. Has anyone adjusted their charting in response to everything? Is this a strategy you use to protect your patients and how? Sorry, I'm repeating back because I know it seems really weird and interrupty of me, but if anybody else wants to do it, feel free. Mental health clinician. They will do the minimum. And they explain to their clients that nobody would recognize what they talked about. But they put minimum components needed in order to protect their patient. So they just put the minimum amount of information needed. Almost nothing. Yeah, never document the last menstrual period anymore. Yeah. I work in repro rights. The answer is yes. Can somebody else do this? Or can we pass this around?
If we think that we're going to continue
I'm not a good listener, is what I learned about.
I think this is a format that doesn't work for streaming, so maybe we can end the stream and continue the conversation.
Sure.
So maybe if you want to go forward.
We are going to end the stream so that we can have a more fluid conversation in Meet Space.
Sorry.
Thank you for joining us.